Ladies and gentlemen, good morning, good afternoon, and welcome to this symposium, which is about artificial intelligence and analytics and how it can help to reduce post-operative complications. I'm the Dr. Visoki. I'm the medical director for GE Healthcare Digital. As an introduction, I would say that's couple of years that we heard about digital transformations, and we already have in our daily life kind of a lot of applications. The first one being the way that we are going to do this symposium this day. But somehow in the medical field, I would say it's very often resonate as a kind of buzzword with great expectations, but still nothing very concrete at the bedside during our daily work, especially in anesthesia or in the ICU. So today we have the great privilege to have two great speakers, brilliant speakers, that will show us two very concrete applications of artificial intelligence, big data, digital transformations in the anesthesia and in the ICU space. Both of them, even if that's from very different fields, will show you how we can reduce post-operative complications with these applications. The first one is about artificial intelligence embedded in the ultrasound device. The second one is about big data and analytics to improve protective ventilations. So the first speaker is Dr. Thomas Hilberg. Dr. Hilberg has been trained in the University Hospital in München. He did a PhD in Boston, Massachusetts, and is now a member of several German organizations about ultrasounds, training ultrasound applications in the ICU and in the anesthesia field. Right. The second one is Professor Philippe Cuvillon. Professor Philippe Cuvillon is working in an academic hospital south of France. He has now, more than 80 publications in PubMed, most of them on post-operative complications. And as I already said, he will show us how to further improve the way that we are protecting the lungs during the surgery in the OR. So again, thank you very much for joining. I hope you will enjoy these two presentations. Again, it's about what everybody is talking about, but now very concrete at the bedside. So please welcome with me Dr. Hilberg about ultrasounds and how they can play a role in reducing post-operative complications in the OR. Thank you very much.
Yeah, thanks for the introduction and for the possibility to present today. I'm delighted to be here today to tell you about the post-operative patient management and how ultrasound and AI tools play a part. Here are my disclosures. I have no conflict of interests. Now I would like to start with a case. I will take you to the recovery room where a 65-year-old male presented to the third-year resident with dyspnea progressing since admission after he underwent surgery and got a placement of a hemodialysis catheter. And not surprisingly, his past medical history was significant for end-stage renal disease, coronary artery disease, hypertension, and a cough that had existed for at least 3 days. He had no fever, no allergies, as you can see. And the initial assessment by the third-year resident was that he took some labs, he did a physical examination on him, X-ray, ECG. So the findings showed a low QRS voltage in the ECG. The X-ray, which has been performed, was not significant to the resident, so did not find any pathology. And after 1 hour, the symptoms were worsening. Vasopressors were necessary, and after 1.5 hours, there was an increasing need for vasopressors. The dyspnea was still worsening, and therefore he called for help. And then the attending showed up and did a point of care cardiac ultrasound. And I will show you quickly a video what the finding was. You see here that pleural pericardial effusion was present. So the patient was immediately taken to the OR, and pericardiocentesis has been performed. After 2 days, he got discharged then to the normal ward. And now you were asking maybe yourself, why does he start with a case? So it reminded me of my first steps in intensive care during residency, and I guess everybody had been in such a situation. This patient here was in absolute shock, and the assessment of gross cardiovascular function, as well as the assessment of causes of hemodynamic instability and shock, were not established due to lack of expert knowledge by the resident. Well, man could say that such postoperative complications are rare in the field of anesthesiology, so bad luck, but that this does not correspond to the facts, I will show you following observational study here. So in this study, Denker and his group evaluated the trends of postoperative complication rates over a 7-year period. They used for their analysis the National Surgical Quality Improvement dataset from 2012 to 2018 to assess 30-day complication incidence rates, including mortality rate, following surgical procedures with 10 surgical subspecialties. So they concluded 5.8 million patients undergoing major surgery in the United States in this study, and there was an increase in total volume of major surgeries performed annually worldwide of 38.2% in 2012 from 2004. Other studies estimate that around about 7 to 15% of all patients undergoing surgery will experience postoperative complications like the common ones listed here. So sepsis, pneumonia, pulmonary embolism, congestive heart failure, myocardial infarction, cardiac arrest. So this proves everybody wrong who thinks that postoperative complications are rare. So what can we do about it? We need to be faster in decision making, and this requires adequate diagnosis, and now ultrasound is joining the game. The term point of care ultrasound, POCUS, refers to a portable ultrasound system that allow the assessment of patients without requiring them to be physically present in a radiology department. So on the left side, you see one of the first ultrasound machines developed by Hitachi in 1960. And as you can imagine, this machine was not portable and required the patient to go to the radiology department. And on the right side, you see one of the recent and newest ones of GE, which is of course portable and enables us to perform everything bedside. So I want to point out that the most essential aspect of a physician's role is our diagnostic capability. If we cannot accurately diagnose pathology, we cannot effectively treat and may cause patient harm. POCUS allows us to assess the patient bedside and provides immediately answers to acute yes or no clinical questions. Thus, it is one of the most rapidly growing sector in medical ultrasound imaging. Recent applications of artificial intelligence and deep learning in healthcare included enhanced imaging modalities to support the clinical decisions and improve patients' outcomes and facilitates pathology identification. And in the acute care setting, POCUS demonstrated utility for almost every bedside assessment, including pulmonary, cardiovascular, airway, abdominal evaluation, and this leads, of course, to an increasing number of exams by multiple specialties. POCUS gained, therefore, widespread acceptance, and although the adoption of POCUS was slower or is still slower in anesthesiology. So from a patient care standpoint, why should the skill set for bedside evaluation just change just because patients undergoing surgery entering the perioperative environment? So here's a nice overview from a review performed by the group Ramsing et al. And they showed just an overview about all investigations we can perform bedside. So from intracranial pressure measurement to vascular access, the possibilities are huge. So we need to focus on what the concerns postoperatively are. From the cardiovascular point of view, concerns postoperatively are change in ventricular function, pericardial effusion, pulmonary embolism, and we use POCUS for the assessment during PEA and asystolic arrest. We assess the volume status. We examine the pulmonary system and the airway to exclude pneumothorax, to diagnose any diaphragmatic function pathology. So you see, multiple ways, and reflecting a trend to integrate ultrasound early into the care of the critical ill patient, multiple resuscitation protocols, as shown below, have been recently developed. And each of these protocols combines many of the same core ultrasound elements, differing mainly in the priority of the exam sequence. So fade, rush, speed, feel, focus. And the most evidence-based for the perioperative setting is the FAST protocol. So as we know now that there is an absolute need to perform POCUS, competencies are somehow missing. So Conlin et al. Conducted a survey under residents and residency directors in the US in 2015. And one of the key messages of the article was that training and utilization of POCUS was highly variable among anesthesiologists. So residents desire to acquire skills in ultrasound methods, but do not receive adequate instruction in POCUS as depicted by them. They considered as a possible cause that professional anesthesiologic society guidelines who demand a minimum of training to achieve ultrasound skills are still missing. And from a scientific point of view, the vast majority of evidence for the utility of perioperative POCUS is unfortunately limited to non-randomized single-center studies. So nevertheless, they stated that incorporation into everyday practice through structured guidelines and mandatory training during residency is needed. Interoperator variability is a long-standing problem proven in multiple studies. Another problem is the relatively slow sensitivity of pathology detection by device users, as shown in this study performed by Thomas Motard. However, due to the high levels of interoperator variations in ultrasound diagnostic, inaccurate diagnosis and incorrect treatment are made. So furthermore, anesthesiologists are faced with the additional challenge to interpret echocardiography and make decisions in a very limited time frame from these complex data. The need for an automated, less operator-dependent process that enhances speed and accuracy of the analysis is crucial for anesthesiologists. So, and now it's time to mention the first time the role of artificial intelligence. So AI is playing an increasingly important role in the medical field and could help anesthesiologists analyze complex data while adding increased accuracy and consistency to the interpretation. When you look around, we are all surrounded already by AI. Look at your iPhone, Face ID. You have Alexa maybe at home. You Google something. So this is everything artificial intelligence. Let me quickly cite the definition of AI. So artificial intelligence is the ability of a computer program to perform processes associated with human intelligence, such as reasoning, learning, adaptation, sensory understanding, and interaction. And the second one here, artificial intelligence refers to a machine or software performing tasks that would ordinarily require human brain power to accomplish. And the important thing is that we are already using AI in anesthesiology when you think about monitoring the depth of anesthesia or the control of anesthesia delivery. The advantages are obvious. AI increases our workflow, enables us to make better and faster diagnosis, highlights clinical findings, and is very helpful for especially novice users. Now I would like to introduce you to 4 ultrasound tools which can utilize to simplify assessments and increase your confidence to make a proper diagnosis during the workup of postoperative complications. And for each of the 4 auto tools, I will show you studies to compare the automatic measures with measurements performed by experts. The group here around Bleivers examined the inter-rater variability of vena cava inferior measurements. They developed a deep learning tool to determine the vena cava collapsibility index in critical ill patients. And the auto tool showed good agreement with focus experts. Also, the differentiation between fluid responsive versus fluid unresponsive in septic shock patients showed good agreement. When treating a patient for shock, evaluating intravascular fluid status is a necessary but challenging step. Automated measurements help to simplify the assessment and accelerate treatment. And in ventilated patients, auto tool measures the IVC distensibility. And if it's greater than 18%, it is a predictor of fluid responsiveness. And in spontaneously breathing patients, the collapsibility index higher than 50% with a diameter less than 20 millimeter may indicate low central venous pressure and requires intravascular resuscitation. I present to you now a video. This is performed on a GE Venue Go. A low frequency phase array of curvilinear transducer is placed in the subxiphoid location. And when you look at the image, you see that it's 2 centimeters away from the right atrium. So the system searches the appropriate place to measure minimum and maximum diameter during the breathing cycle. And then yellow labeled means that the results showed or the results should be taken with caution. And if it's marked or highlighted in green, then this shows perfect match with the measurements of an expert. So let me lead you to the next AI tool named Real-Time Auto EF. the accuracy and reproducibility of this measurement is also backed up by 2 studies as following. Here in this study, Ash et al. Showed that automatic calculation of EF using a deep learning algorithm was accurate when compared to expert cardiologists, and as well the reproducibility of EF calculation was highest for the deep learning ejection fraction. So the next study I will show you here is performed by Nuxted, and they showed that fully automated analysis of echocardiography images provides rapid and reproducible assessment of left ventricular ejection fraction. Now I go on with here the video. Hopefully it does work. Yeah, this is the automatically traced border of the left ventricle. And as you see, evaluation of left ventricular function could be critical to a patient's course of treatment. So undiscovered LV dysfunction could delay a critically ill patient's treatment, causing severe complications, including death. Normally use the Simpson biplane measurement. And that means that you use an apical 4-chamber view and a apical 2-chamber view, and then both the end diastolic and systolic frames are identified. The LV endocardial border is traced manually, and then you get the results of the end systolic and end diastolic volumes. Then EF is being calculated by the system according to the volumes measured. So as you hear already, it's very time consuming and a disadvantage for the unstable patient. So when using the auto tool here, you only need a apical 4-chamber view, and this is required, and EF is then automatically calculated within seconds when image quality is sufficient as determined by the quality indicator. As a few studies showed that measurement of velocity time integral outperforms EF measurement, I want to quickly guide you through this novel auto tool as well. So VTI is used to calculate the stroke volume, and measurement of VTI answers a couple of questions. Is my cardiac output sufficient enough? Did my intervention work? Is the patient hemodynamic status changing? Aortic VTI is a simple measurement with good reproducibility, even by beginners, as shown by Jolly. And even minimally trained operators can reliably quantify aortic VTI, as data has shown. As well here, I show you a video. So it's necessary here to perform an apical 5-chamber view. And again, the quality indicator is displayed, green, yellow, red. And when green, it's highly likely to match calculations created by an expert, as previously mentioned. And to calculate the cardiac output, you just need to enter the diameter of the left ventricular outflow tract, and then you get automatically calculated the cardiac output. Right. So, and last but not least, I want to show you an auto tool which is used on a daily basis for the assessment, not even for COVID-19 patients, as well as for the differentiation of volume overload versus cardiogenic shock in septic patients. It's the auto beeline tool, and this was highly reliable among COVID-19 patients. So for this measurement, you have to select the C1 to 5 probe, and the auto beeline tool highlights then and count the beelines in the desired lung space. So when live scanning, you see here the quality indicator disappears, and again, when green, the results matching experts' measurements. And the B lines are then counted and shown in the display frame below. So the system will automatically display the frame with the highest B line count. Now I have reached the end of my talk, and I would like to summarize the following conclusion. So post-operative complications will definitely increase in future. And as a diagnostic tool, number one, POCUS will continue the triumphal march. And as a matter of fact, residency programs around the world need to think about incorporating professional training in core competencies in POCUS. AI will remain an integral concept in the future, and AI tools, I guess, will definitely be crucial for anesthesiologists, as it allows automated analysis and is less user dependent on operator effect. Nonetheless, we all must be, of course, be aware of the advantages and limitations of this technology. And most people are concerned that AI will replace at some point doctors. So I guess that rather specialists who leverage the power of AI may replace those who do not. So here are my references, and yeah, thanks for the patience, and I'm eager to hear your questions. Thank you very much.
So dear friends, the organizer of this symposium, and in particular, thank you for the support of Industrial General Electric. I have the honor to present you this slideshow entitled How High Fidelity Matching Data Support Protective Ventilation Strategies in the Operating Room. I have, of course, conflict of interest that are noted on this slide. I'm sending you sunshine from the south of France, where my University Montpellier is located, and my hospital, Carremo, Nîmes, which is a Roman city and with ancestral tradition with a sports ring known throughout the world for 2,000 years, of course. So now, as you know, more than 300 million patients undergo surgery worldwide each year. Post-operative complications increase treatment cost, of course, and reduce both life expectancy and quality of life, and occur in up to 20% of patients after major surgery, probably. Elective surgery, and finally, in-hospital mortality is close to 3%. When regarding this map of the world, all countries need attention. Most frequent surgery inducing mortality were, in this report, major abdominal surgeries, including upper gastrectomy and liver. Also, we can say that poor patient outcomes are common after inpatient surgery, and this is a problem over the world. When regarding patient hospitalizations after surgery, patients in ICU presented lower mortality rate at 30 days due to most pulmonary and cardiac attention. Global initiative to increase access to surgical treatment should also address the need for safe peri-operative care, of course. Question remains about the correlation between surgery and pulmonary complications. You know that the most severe form of perioperative lung injury, acute respiratory distress syndrome, has been historically reported in 0.5 to 3% of surgical patients at high risk, leading to a significantly greater risk of postoperative mortality. This report included 40,000 patients. Of those, 7,000 patients died within 30 days of surgery. 5 days occur only in the operating room, but 500 days occurred after surgery during the index admission to hospital, and 200 days occurred after discharge from the hospital. Among patients undergoing non-cardiac surgery, 99% of deaths occurred, of course, after the procedure, but only half of deaths were associated with 3 complications: major bleeding, myocardial infarctus, and sepsis. Given this finding, focusing on the prevention, early identifications and management of these 3 complications also promised for reducing perioperative mortality. In ICU, of course, for ventilations, many authors have recommended the use of protective ventilations to reduce the complications of flight and barotrauma. These measures, you know them, are the applications of low tidal volume, high PEP level, and probably a recruitment maneuver. Several steps have been suggested to treat and limit pulmonary complications, as you can observe on this slide. These recommendations are similar for patients with COVID disease, and this is the last expert consensus statements produced by a Critical Care Journal, of course. So next question is how and why adjusting the ventilation setting can reduce the incidence of pulmonary complication, especially in the operating room. It has become clear that mechanical ventilation can trigger an inflammatory reaction in the lung, and that the degree of inflammation depends on the ventilation strategy. Furthermore, this inflammatory reaction may not be limited to the lungs, but may also initiate and propagate a systematic inflammatory response, possibly contributing to the onset of multi-organ failure. The biotrauma hypothesis proposes that biophysical forces alter normal cellular physiology in the lung and lead to increases in local mediator levels and change in pulmonary repair, remodeling, and apoptic mechanism. Mechanical ventilation generates pressure on the lung tissue and especially on lung cells. Depending on the extent of the physical forces applied, this stress may lead to activation of pulmonary cells through mechanotransduction or to rupture of membranes and tissue destruction. This data suggests that a key inciting event leading to biotrauma is cyclic stretch-induced lung injury. So the next question is for clinical practice. Does intraoperative may change mortality and mortality after surgery? So several studies were published, pro or con study have to be discussed. First, in this randomized clinical trial of adult patients undergoing major surgery, in this study, intraoperative mechanical ventilation with low tidal volume did not significantly reduce postoperative pulmonary complications when compared with ventilation with conventional tidal volume when PEP was applied equally between groups. But this kind of study are not very important. So in this other study published in Anesthesiology, in this study, pulmonary postoperative complications, there's a well-documented group of complications following cardiac surgery are associated with a four-fold increase in mortality, extended intensive care unit, and hospital length of stays. Authors identified an intraoperative lung protective ventilations bundle, this is very important, the notion of bundle, as independently associated with pulmonary complications following, in this case, cardiac surgery. Their finding offers insight into components of protective ventilation associated with adverse outcomes and may serve as targets for future prospective interventional studies investigating the impact of specific protective ventilation strategies on postoperative outcome following, for example, cardiac surgery. To summarize the POP ventilation strategy in the operating room, Emmanuel Futier and Samir Jaber have proposed a simple algorithm that starts pre-operatively and ends after surgery. They propose a triad, and this triad is low tidal volume, high PEP level, and recruitment maneuver. But recruitment, as you know, is a source of controversy because its value and timing are debated. We just recall this study in which we participated and which adoptably best reports the interest of POP ventilation by comparing two strategies, one protective and the other not. And you can observe on this slide the very important difference between the two groups, one group with POP ventilation strategy and the other not. Other studies have also shown that this strategy, this POP ventilation strategy, can also be related to the level of PEP, of course, and also with the level of driving pressure, as demonstrated in this study and published by Neto in this report. Additionally, recent data suggests that recruitment maneuver may not confer a benefit when used solely as an adjunct to conventional ventilation. As this strategy has been shown to lead to an increased incidence of pulmonary post-operative complications and intraoperative oxygen desaturation compared with low tidal volume, moderate PEP ventilation during laparoscopy surgery. As previously noted for other techniques, the benefit of recruitment maneuver may be most pronounced when incorporated into a package of intraoperative lung protective ventilation. We can say bundle, for example. I invite you to read this recently published recommendation. This is recommendation for lung protective ventilation for the surgical patients. And this is a very interesting report for all the strategy that can be proposed in the operating room. So next question is, do you use protective ventilation in your operating room? Do you use it? Of course, I use it. There's no doubt about this. But you, in your operating room, how can you be sure? Also, you need data for this response. So, the Las Vegas study, you know, this study proposed to answer this question using paper reports that are recorded at each procedure by the anesthesiologist, who notes the ventilator parameters and the modifications that are made. This study was performed in 146 hospitals in 29 countries. So during the intraoperative period, they collected data on intraoperative ventilation settings and vital parameters early and recorded intraoperative events possibly related to mechanical ventilation. They recorded tidal volume, respiratory rate, PEEP, recruitment, and so on, so on, so. And they collected more than 1,400 data during this study. What can we say about this data? Ultimately, the questions that arise are this data correct? Are this data well collected, of course? What about missing data? And is it probably possible or not to collect automatically all this data and procedure and publish this on dashboard? Of course, we can propose this, probably with a specification of an automatic reporting with a software as a service via cloud. And this innovation consisted of using a software package with an automatic data collection as soon as a new patient case is opened, with no human intervention, with dashboard prediction, and probably to help make data-driven decision more evidence. So, software orchestration. This is a suite of analytical apps powered by IZCDU anesthesia delivery system via an RG45 socket. It captures and analyzes over 300 data points from the anesthesia machine, including ventilation setting and measurements, recruitment procedure and gas values, alarms, machine status, and error codes every patient breath, every patient breath. This is very important. It transfers them to a cloud via a specific domain. And this software leverages one data stream per operating room for each machine connected to the device. For this study, we specially analyzed tidal volume, PEP level, plateau pressure, driving pressure that were automatically collected and calculated by software for all of this data. All data were recorded in a specific domain of the cloud and extracted for the study after each period. The dashboard could be consulted in PDF format, as you can see and observe on this slide, in a shared hard disk of the department and consultable by all practitioners, in addition to the staff presentation at the end of each period, of course. To summarize, we can compare to analyze for intraoperative data, a software solution compared to what can we say, a traditional reporting. And you see and can observe the difference between the number of data for example, for 10,000 patients, it's very different. We compare billion data compared to only 1,000 data. There's no difference, of course. So what are probably the objectives for my anesthesia department? Probably to be sure that they applied the good level of tidal volume, PEP, recruitment maneuver, and driving pressure in the intraoperative period. So we published and we will publish an interesting study. We propose in clinical practice management of operating room using this software. So we perform a clinical study by audits evaluating the software package in 9 operating rooms. Exclusion criteria were surgery less than 1 hour and regional anesthesia. And we collected the level in percentage of triad, including tidal volume, PEP, and recruitment maneuver. We performed 5 steps. So step 1 was baseline. This was just a photography of the practice. Step 2 was informations and training during a second period. Then we stopped information and training during the step 3. This was over time. Then we perform an implementation of the system with a pop-up message on the screen of the anesthesia machine that appeared after each procedure. And then we perform a last step 2 years after the beginning of the study to be sure that the implementation continue over time. For the baseline, we included more than 2,000 patients. It's very important. And on this slide, you can observe the baseline characteristic of the patient with a low level of PEP and the very, very low number of patients that had a recruitment maneuver during the intraoperative period. So you can observe on this slide the step 2 and the step 3, and you can observe after training and recommendation that the recruitment maneuver increased, and after the third period that the level remained very high for this recruitment. And you can observe the number of patients included for each period. It's very, very high number of patients, because this is with this software automatically records the data for all the patients during the period. So this is the slide shows the percentage of triad performed per period and the number of patients included for each period. And you can observe that after 2 years, after the long overtime period, the number of patients with the application of the triad is 22% compared to 7% only for the first period. It's very interesting. So in conclusion, this quality improvement project demonstrated the low adherence of the POP ventilation strategy when regarding level of PEP, low tidal volume, and recruitment maneuver at baseline, but the interest of several interventions to enhance adherence to the trial for an intraoperative lung protective strategy is probably a good way with this software. Our study also demonstrated the benefit of an automated cloud-based data system for analyzing LPV strategy and its implementation at each period, reducing time-consuming written reports, improving objectivity, and increasing data over several operating rooms to enhance perioperative patient care. You can perform also agent cost and emission analysis with the software to produce dashboard for this data. So in conclusion, thank you for your attention. I think that using this new software and improving pop ventilation with this strategy and with the help of the software is a new way to improve and promote health care in your operating room and probably for mortality and morbidity of your patients after surgery. Thank you very much.
So thank you very much, Dr. Hilberg, Dr. Cuvillon, for this two great presentations. We now have a couple of, well, more than this, minutes for questions and discussions. I have a couple on my side, but maybe do you have, Professor Cuvillon, some questions for Dr. Hilberg and vice versa? But let's start with the presentations from Dr. Hilberg. We have some questions or not? I have on my side, but in case of, just being polite.
Yeah, hello, Thomas. It was a very great. So, okay, I think the sound is okay. Thank you, Thomas, for your presentation. It was a pleasure for us to see you, to hear you, and to show this beautiful presentation of ultrasound and applications for perioperative patients. So I just have a question for you. Do you think that in the future, all of this software ultrasound will be more helpful and very more simple for the educations for residents to learn all of this technology?
Yeah, Philip, thank you so much for this question. I think we need, in general, put more energy into the education on the ultrasound machine during the residency. So, and I think in the future, AI will definitely help even to hire the self-confidence of the residents when they perform the ultrasound, because most of the time they are already lost when they need to put the probe in the right position, you know. So you need to train the basics, but when you then can support the basic skills with, for instance, the measurement, the automatically measurement of the ejection fraction, then on the one side, they're very happy because they get something out of it and have directly the result and have the patient here and they see, oh yeah, my measurement, oh yeah, it works. I can evaluate the patient with minimum skills from now on. And I think this will be the future. So they will need to gain the I think the step one competencies, and then with the addition of AI, it will increase and the speed of their training and their skills.
In the same kind of topic, I also had questions and a point that we already discussed. Maybe that's a bit crazy, but there are already some kind of publications about robotic surgery is something that is already existing, and right. I mean, there are also some publications about robotics, kind of endotracheal intubations, right? I mean, I've seen some papers on that, and people in Montreal doing this, and in some other place, right? So I'm just wondering how much we can think about robotics applications that help the juniors or whoever, to place the probe properly, and then saying, right, turn left, turn right, do this, do that, in a sense of somehow someone without any kind of training being able to do that. And just at the topic, you know, last year during the same Congress, there were some presentations about, you know, anesthesia in the space, right? I mean, when people will go to march, you know, and something happening, then someone in this place needs eventually being able to do an ultrasound, you know, and maybe probably having no clue, no education, even no medical knowledge, if you want, right?
Right. It's a very good question, Mark. So as far as I know, such systems are already on the market. There are not many, but a few. And the system work like they provide a workflow, and you have a workflow-based protocol or indication-based protocol. So you have to choose what you want to do. And then the system provides you on the one side with a diagram how to position the transducer. And on top, for instance, on the diagram, there's a reference image, which shows you what the current view the person is scanning for should look like. And on top of that, you will find some guidance prompts to make specific transducer movements to optimize the image. And once you have optimal diagnostic image detected by the system, it automatically starts the measurement and records the examination. So yeah, overall, I'm pretty much sure that AI will in that category revolutionize the way we think and the way we use ultrasound in the future. And a robot-assisted ultrasound makes, from my perspective, sense, but only if the doctor in charge has superior knowledge in ultrasound diagnostic, because somebody have to make sure that everything what the system refers to is on the one side makes sense and is correct, not that we harm a patient just based on any robot's diagnostic. So the resident have to make sure that he has superior knowledge, and this kind of like is similar to what he would measure. So
yeah. Well, and don't get me wrong, I mean, because I have a lot of comments here, you know, I mean, this is already a fantastic improvement and help, you know, to support you know, the diagnostic, the evaluations, calculations, and all this. Over the last, I would say, 10, 15, 20 years, we've made a fantastic improvement in what kind of informations we can get from the ultrasound. So that's no comparison, right, between, you know, today and what we had 20 years ago, right? I mean, this is fantastic. So no doubt about this. Maybe one question, a quick one, and that's also something that we discussed. I'm thinking about, you know, as I told you, I'm on the digital side, so we are thinking about, you know, all that kind of information coming from everywhere. And in the ICU or in the ER, there are plenty of device informations and all this. So how to make all this more or less together, right? I mean, to also to make it easier for the user, but also to get some additional information by contextualizing, right, that information, that image coming from the ultrasounds, right? I mean, you kind of, you know, thought about this?
I mean, integration of data, or more precisely data collection, so using whatever collected data is always helpful. I mean, when you think about now the COVID-19 situation, if we could combine data from ventilator generation, or for instance, the B-line count, what we do in the ultrasound. So if you could combine these data, it would be so helpful. But one requirement which you have is that you have a patient or electronically patient-based management system in your hospital. which brings all the data together. And then the more data we collect, and we collect so many variables during the day, would be great if there would be an interaction between ultrasound, ventilator, and medication, for instance.
Yeah. Thank you very much, Dr. Herbert.
You're welcome. You're very welcome.
Thank you. And returning the politeness to you, if you want to shoot first for questions to Dr. Cuvillon, please feel free.
Of course. Philip, I was very curious about how many variables you collect every day, and you said you collect it in your cloud. So what can you get information-wise out of your system in the hospital?
It's a good question, Thomas, and it's similar to your creation and your idea about ultrasound and new technology. So with the device, as I described before, we can collect a very important number of data, more than 300 data per each breath. More than 300 data per each breath. It's very important. But I think that the most important is what in your operating room, what is important in your practice and for your patients. For example, I just need for my operating room a dashboard that record only 3 important data. For example, it's the level of tidal volume, the level of PEP, the level of recruitment, to be sure that my practice is conformed to the recommendation. So I use all of this data with retrospective use to be sure that recommendation for patient safety is in accordance with recommendations. But you can also use differently all of this data to improve other parameters. And I think that what is very important is before you start with this technology, it's similar with ultrasound. You have to discuss with your practitioner, you have to discuss with your staff, and to decide what is important, what is the data is very key for my practice. Because when I say to you, we can collect 300 data at each breath, there's no sense in practice, of course, yes. And you just have to select 3 to 10, it's very important data, and to analyze and to make audit, to make implementation in your practice. And this is, I think, a good way. So I propose in my institution to use the app from General Electric to see what is important with this application and what should improve our practice. And I think this is a good way.
Thank you.
Thank you very much, Dr. Cuvillon. I have on my side one question. So 2 minutes left. I'm not sure that you will be able to answer, but it's about what we used to call in the company expectations management. In a sense of you move from 7% to more than 20%, if I well remember. So it's a 3 times increase in the compliance to the guidelines, to the adherence to the guidelines, and that's a fantastic results, right? I mean, it's super impressive. At the same time, I'm sure that on the other side, people will tell you, yes, great, but that's still 20%, right? We are far from 100%, 80%, 60%. So my question is, what is the expectations? Maybe the expectations can be more on tidal volume, a little bit less on PEEP because it's more complex depending on the patients and difficult to know what's the best PEEP, and maybe more complex and even more on recruitment maneuvers, as you say, because the guidelines are somehow a little bit, fuzzy. So how do you manage this? I mean, in a sense of here you improve from 7 to 20%. What's the next? What's next? Where do you want to go? Do you want to go to 30%, 40, 50? Do you want to make this kind of expectations differently depending on the tidal volume, PEEP, recruitment maneuvers? So just, as a...
It's a good question. I don't know what is the best step, and if we have to perform for everyone recruitment maneuver. It's a job. I don't think it's very important. So for me, the first step was to be sure that we use for more than 90% of our patients, of our populations, the good tidal volume. I think it's the first key. The second key is to be sure that for major surgery, most of half of the patients had the good level of PEP between also 5 to 10, for example. So, and the next step, it's to correlate, to perform a correlation between those 2 or 3 parameters with morbidity and mortality, and to describe for the anesthesiologist the good way for to decrease mortality and morbidity for specific population or for specific surgery. For example, cardiac surgery. You know that it's very difficult to say if we need to perform pop ventilation or not for this surgery. Actually, we know that it's probably a good way for this surgery. So next step is to develop and to increase all of this data to make recommendation for specific surgery or for specific topic. For example, for pediatric surgery, you know that we have to perform pop ventilation, but recruitment maneuver is still debated. So we have to collect more data and to analyze data for this specific population.
Okay, thank you very much, Professor Cuvillon.